in August of 2010, we decided to set up a program that functioned in two categories within the hospital. One was those patients who were going to be pre-surgical patients, and the others were the patients that were transferred from another institution or had had a previous history of methicillin-resistant Staphylococcus aureus, which is MRSA or MRSA, for the last 12 months. And so what we looked at is two programs. One is called the Infection Reduction Program, and the other was the Active Surveillance Program. When a patient comes in from another institution or has been diagnosed or has a history of MRSA over the last 12 months, they're automatically put into isolation. In Kettering's case, from August of 2010 to August of 2011, that was 707 patients. Now what was interesting is all those patients were put into isolation the day they were admitted in the hospital. Within 24 hours, we were able to take 67% of the patients out of isolation. Why? Because of the definitive nature of our technology, we were able to take the patients out of isolation because they didn't have colonization for MRSA. Colonization is very important to understand because if you're colonized and you're in a hospital, you probably do need to be isolated. There are pathogens that can be harbored in our body, usually within the nose, can be in the axilla area, under the arms. Now your other normal flora, keep them in check. If you become traumatized or immunosuppressed, when you have surgery, you will be immunosuppressed. Those organisms are opportunistic. Now all of a sudden, they'll transfer and they can contaminate your wound and now become a full infection. So what's happened is it wasn't acquired by the hospital, you cross-contaminated yourself. So if you treat that with a nasal antibiotic or a topical antibiotic and eliminate the colonization, then your chances of conversion to a full infection has been not eliminated, but at least diminished. The second population were pre-surgical patients. These are the patients that were going to have a major surgery in cardiovascular, neurosurgery, or in orthopedic surgery. We actually tested the patients in the surgeon's office 10 days prior to surgery. If they were positive, and 15% of the patients were positive, we decolonized them. These patients aren't infected, they're colonized. It's a 5-day procedure that uses a nasal antibiotic, chlorhexidine soaps for baths, and we retested the patients prior to admission. When they were negative, they went on to surgery. What's interesting about the outcome of that is there were no post-surgical infections, also no isolations. Isolation is somewhere between $750 and $1,500 a day. In the case of Kettering, that was over 700 patients. If you look at 23% of those patients, comes out to about 178 patients at $14,000. That was $2.4 million that it would have cost them. Prior to us doing this program, they were given an antibiotic that was called vancomycin. Now, vancomycin is nephrotoxic, which means it's hard on the kidneys. We reduced 4,200 doses of vancomycin from the system. That means patients didn't get the inappropriate antibiotic. And therefore, what happened on the outcome, we did 7,000 patients. And since January of 2011, Kettering has had no infections based upon this program.